So I would like to now introduce our speaker, Dr. Robert M. Jacobson. Dr. Jacobson is a primary care pediatrician at Mayo Clinic in Rochester, Minnesota. He is the medical director of the immunization programs for both adults and children for the primary care practices in Rochester, as well as in Southeast Minnesota Mayo Clinic Health System. He is also the medical director for the Population Health Sciences program at Mayo Clinic and conducts research investigating how to improve vaccine coverage. He teaches the principles and practices of pediatric research, as well as evidence-based medicine to pediatricians in training. He lectures widely on topics concerning vaccines. So Dr. Jacobson, thank you for being willing to share your knowledge with us, and please take it from here.
Thank you. I'm delighted to be able to talk about what's new with flu and COVID-19 vaccination, making sense of the latest recommendations. I have a number of learning objectives for this talk. That at the end of the session, you'd be able to relate the latest recommendations for flu vaccination and explain the basis for those changes, as well as relate the latest recommendations for COVID vaccination and explain the basis for those changes. With regards to flu vaccinations, I want to address what's new with flu vaccine. Well, the strains themselves this year have been changed. The number of strains across the different brands and types of flu vaccines, the recommended timing of the flu vaccine, and the management of flu vaccine allergies. Let's start first with the fact that now all vaccinations offered across the country are quadrivalent this year. All contain two A strains, one against the H1N1 strain, one against the H3N2 strain. And these were both updated this year and are different strains than we used previously. And there's two B strains, and these are unchanged from last year. We still had last year some vaccines that were trivalent that only included one B strain, but now all of the vaccines available to us have both 2A and 2B. The change in the A strains was based on three major factors: the recent flu isolates that have been found circulating around the world, the serologic or antibody response to the 2020-2021 vaccines, and the performance of last year's vaccines. Not just whether they worked, but also how well they were manufactured. There are four major types of flu vaccines available. The inactivated vaccines are egg-based, given intramuscularly. These form the bulk of the brands available, but there's also three others: a live attenuated vaccine that's also egg-based, given intranasally, a cell culture-based inactivated vaccine given intramuscularly, and a recombinant vaccine given intramuscularly. These last two are not egg-based. Egg-based flu vaccination, such as the inactivated influenza vaccine, is abbreviated IIV. These are all intramuscular. There are multiple brands and manufacturers for children 6 months and older through adults. These include Afluria by Seqirus, Fluarix by GlaxoSmithKline, Flulival by GlaxoSmithKline, Fluzone by Sanofi Pasteur, the Fluzone High Dose by Sanofi Pasteur, made for those 65 years and older. The adjuvanted Fluad is made by Seqirus, that's also made specifically for those 65 years and older. Finally, one of the egg-based flu vaccinations is a live attenuated influenza vaccine abbreviated by LAIV. It's a nasal spray, and its brand name is Flu Mist, and it's made by MedImmune, and it's for individuals in the 2 years to 49 years age range. We also have the non-egg-based flu vaccinations. These include the cell culture-based inactivated influenza vaccine, abbreviated CC in lower letters, IIV in caps. This brand name is Flucelvax, quadrivalent, made by Seqirus for those people 2 years and older, and recombinant influenza vaccine, or RIV, has the brand name Flublock, quadrivalent, made by Sanofi Pasteur for those 18 years and older. Now, One of the big changes in the recommendations was clarity on the timing of vaccine. Everyone should be vaccinated by the end of October. We still play catch up the rest of the flu season. Mayo Clinic in Rochester, Minnesota, in Florida and Arizona, across Wisconsin and Minnesota and Iowa will continue vaccinating all the way up to June 30th because we continue to see cases of flu most seasons right through that entire period. But we should have got everyone vaccinated by the end of October, according to the Advisory Committee on Immunization Practices. July or August is too early for those 65 years of age and older. Early doses may result in waning protection for this age group. The vaccine studies regarding this are not 100% all on the same page with that result, but a smattering of studies do indicate the potential for waning in this age group. Those vaccinated this early in July or August are not to repeat the doses, however, or get boosters. Just try in the future not to discourage vaccination when the vaccine becomes available until September. July and August flu vaccination may make sense for two groups. This is a surprising change from the previous year. Those pregnant who are due to deliver before September, October should get the vaccine while they're pregnant to protect that newborn infant for the coming 6 months entering the flu season before that baby can get vaccinated when the baby turns 6 months of age. It protects both the mother during the pregnancy and their two young babies to be vaccinated. Another group that should also get the vaccine in July or August, if available, are children who are going to require 2 doses. Those are those children less than 9 years of age who have only received 0 or 1 doses before July 1st of this year. And that means they need 2 doses this season. And it's hard to get in 2 doses before October ends. And so those might take advantage of July or August as well. Another big change this year, without much fanfare, was new clarity about and new instructions on how to manage people who have had a true allergy to a previous flu vaccination. Previously, severe allergic reactions was a contraindication to further flu vaccines. No matter what type of flu vaccine the allergic reaction was to, and no matter what type you had available. The severe allergic reaction is another name for anaphylaxis. And we're talking about any previous influenza vaccine of any type for all future influenza vaccines of any type. Well, we now have new recommendations. By the way, these reactions were rare, but can occur despite a lack of history of having a reaction to a previous flu vaccine. Occasionally they do happen. The new recommendations take into account the various vaccines now available. They leave some vaccines as contraindicated, which is another word for prohibited, but they list other vaccines precautions, meaning consider the benefits and risks and sometimes proceed and sometimes don't proceed. This is a new table with the rules about flu vaccine allergy. And we have, and I think the table's mislabeled. It says egg-based flu vaccinations. What it really should be labeled as basically a table of how to proceed no matter what the vaccine was. Now in this table in the left-hand column, you see vaccines of any valency, whether it's trivalent or quadrivalent, associated with the previous severe allergic reaction. And then you see in that first column, 4 rows. We're going to be talking about what to do with any egg-based IIV or LAIV in the past, any CCIIV allergy in the past, any RIV allergy in the past, and when the past flu vaccine is unknown. Then you're going to see 3 columns over on the right. These are the available 2021, 2022 influenza vaccines. The second column's listed egg-based IIV4s and LAIV4. The next column is the CCIV4, and the final column is the RIV4. And you can see that if you had a previous reaction to any egg-based influenza vaccine, whether it was injected or nasal spray, you are not to get any future egg-based vaccines. That's contraindicated. But this history of any egg-based reaction is only a precaution for the cellular vaccine or the recombinant vaccine. Similarly here, for the cellular vaccine reaction in the past, any egg-based is a contraindication, as is any further cellular based vaccine as a contraindication. But you might consider the recombinant vaccine with a precaution. Similarly, for a recombinant influenza vaccine history of an allergic reaction in the past, the egg-based is contraindicated. The recombinant vaccine is contraindicated, but you might consider the CCIV4 with precaution. Now, if the past vaccine reaction is due to an unknown type flu vaccine, the ACIP recommends allergic consultation. Now, what flu vaccines? Well, one more. What's not new with flu vaccines this year? That we're vaccinating once again this season. That's not new. We do this every season. But we did have an absence of flu worldwide since March 2020. It was the result of lockdowns, masking, and social distancing that not only controlled the COVID-19 pandemic, but also really stopped flu in its tracks. This was not a result of failure to test, report, and distinguish from COVID-19. Worldwide, actually, if anything, there was increased activity trying to find the flu when investigating cases of COVID-19. The last few months around the globe, we have measured influenza B activity. Now, I do want to stress that while I talk to you about flu vaccine allergies, there still remains no apparent risk of an allergic reaction with the flu vaccine among those who have egg allergies. Whether it's a serious egg allergy or not, that does not appear to increase the risk of a serious egg reaction to the flu vaccine. Everyone is recommended to get the flu vaccine this season, despite the poor numbers you saw in the previous presenter slides regarding Michigan, Minnesota, and Wisconsin. We've got work to do. Experts fear a lack of circulating flu in the last year and a half may actually cause a drop in natural immunity due to acquired flu infections and may actually leave us really set up for a big flu epidemic once our guard is down. Experts call for continued seasonal vaccination against the flu. Now, one more update about flu and COVID-19 vaccinations. Previously, when we were first rolling out COVID-19 vaccine, there was the rule of no simultaneous same-day vaccination with the flu vaccine or with any other vaccine. In fact, you were not to even permit a spacing between vaccines of less than 14 days before or after that COVID-19 vaccine. That applied to all vaccines, including influenza. Now, this was a big change for us in the vaccination world because the rule with COVID-19 vaccine was different than our usual rules with inactivated vaccines. Yes, we have the 28-day rule with live viral vaccines like measles, mumps, rubella vaccine, but we never had a rule to avoid putting together different inactivated vaccines together or close to each other. And there was no data really to support this other than that's the way the COVID-19 vaccine trials were conducted by avoiding side effects from other vaccines to be confused with the COVID-19 vaccine. But the current recommendations are changed. You can certainly vaccinate simultaneously on the same day vaccination with any vaccine. With COVID-19, that's fine. There's no minimum interval before or after the COVID-19 vaccine and any other vaccine. Now, there have been a lot of changes in the last few months with COVID-19 vaccinations. First of all, we have universal COVID-19 vaccination for those 12 years and older, with the expectation that we are going to hear from the Advisory Committee on Immunization Practices today about a decision for a recommendation for those 5 to 11-year-olders. Furthermore, we have recommendations now for additional doses. For Johnson & Johnson Janssen vaccines, a second dose for all, and for Pfizer and Moderna mRNA vaccine recipients with third doses for those who are moderately or severely immunocompromised, and booster doses for mRNA vaccines for high-risk groups. Furthermore, we now permit mix and match. Let's go into some detail. For universal COVID-19 vaccination, for those 12 years and older, we have the Pfizer-BioNTech mRNA vaccine that's branded Comirnaty. Now, I don't work in marketing, but I cannot figure out that name. It is an mRNA vaccine in lipid nanoparticle. That not is an error. I don't know what it's doing there. I'll fire the people who designed this slide for me. Just kidding, it's me, I gotta do it. I'll fix it before I distribute the PDF of the slides to you. The mRNA codes for the viral spike glycoprotein of SARS-CoV-2. It's licensed for those 18 years and older. That's the full licensure, but we have still emergency use authorization, or EUA, for those 12 through 17 years of age. It's 2 doses, 21 days apart, given intramuscularly. It comes in a purple vial cap. It's a 30 microgram dose, and it's 6 doses per vial after dilution with the diluent provided. The injection volume is 0.3 milliliters. The other vaccine we have, in addition to the Pfizer-BioNTech mRNA vaccine, is the Moderna mRNA vaccine, brand name Spikevax. Still wondering about the people who do our branding of vaccines. This still is under emergency use authorization, or EUA, for those 18 years and older. It's a similar mRNA and lipid nanoparticle as the Pfizer-BioNTech vaccine. 2 doses, 28, not 21 days apart, given intramuscularly. It has a red vial cap, 100 microgram dose, and depending on the vial that you've received, either 11 or 15 doses per vial with no dilution. The injection volume for this vaccine is 0.5 milliliters. The third COVID-19 vaccine we have for those 18 years and older is a Johnson & Johnson vaccine, Janssen COVID-19 vaccine, PF, meaning preservative-free. It's under an emergency use authorized for those 18 years and older. It is not an mRNA and a lipid nanoparticle. It is instead a non-replicating recombinant human adenovirus vector. It's that presents the DNA of the adenovirus coding for the same spike glycoprotein that those mRNA vaccines do. 1 dose is given intramuscularly. It comes with a blue vial cap, and there's, rather than micrograms, we measure viral particles, though it's not a live virus vaccine, that is 5 times 1010 viral particles per dose, with 5 doses per vial and no dilution, with an injection volume of 0.5 mLs. Now, what about this COVID-19 vaccine for 5 to 11-year-old children that we might hear about today from ACIP? This will be the Pfizer-BioNTech mRNA vaccine brand with the brand name Comirnaty. We already have an emergency use authorization that we got Friday last week, October 29th, for those 5 through 11 years of age from the Food and Drug Administration, but they are not the be-all and end-all for vaccine recommendations. In fact, they just licensed the manufacturer. It is now up to the U.S. Advisory Committee on Immunization Practices to make a clear recommendation on the use of this vaccine, and we await that. They are meeting today. This is a U.S. committee that is hosted by the Centers for Disease Control and Prevention, or CDC. The ACIP is the only body to make federal vaccine recommendations for civilians, both adults and children. Its meeting today is scheduled for November 2nd. This vaccine will be different from the Pfizer we use in adolescents and adults. It will have an orange vial cap, not a purple vial cap. It will have a 10 microgram dose and 0.2 milliliters after dilution, not 30 micrograms and 0.3 milliliters. And there will be 10 doses per vial after dilution, not 6 doses per vial. So it will be different. The COVID-19 vaccine for 5 to 11-year-old children first began with trials in this age group that compared the 10 microgram dose to 20 micrograms and 30 micrograms. The 10 microgram actually produced the same immunogenicity, that is antibody levels measured, as a 30 microgram dose did in young adults. The 10 microgram dose has the same reactogenicity as a 30 microgram in young adults. I fear it was the 20 and the 30 microgram doses in this age group that just produced way too many reactions for comfort without any real improvement in the immunogenicity. And that's why they went with the lower dose for this age group. Phase 2 and 3 trials in this age group with the 10 microgram dose involved 1,968 children from across the country, 5 to 11 years of age. The first COVID-19 infection were measured as the outcome only if they occurred 7 days or more after the second dose. There were 3 cases in the 1,305 children who got the active vaccine. That's a rate of 0.2% infected in the vaccinated group in the months after the vaccination, as compared to 16 out of 663, or 2.4% infected in the placebo-injected group of children. This is an efficacy rate of 90.7% with a 95% confidence interval that runs from 67.7 to 98.3%. The COVID-19 vaccine for 5 to 11-year-old of age also compared antibody levels of those 5 to 11 years of age with those adolescents 16 to 25 years of age 1 month after a second dose among those who had no evidence of infection. So the antibodies we measured were only due to the vaccines. Using the SARS-CoV-2 neutralization assay with 264 infants, children 5 to 11 years of age with 2 microgram doses, they found 99.2% seroconverting with a 50% neutralization titer of 1,197.6. This gave a very nice narrow confidence interval of 1106 to 1296. And they compared that with 253 adults, 16 to 25 years of age, who had 230 microgram doses. 99.2% of them seroconverted with this 50% neutralizing titer of 1146 and a confidence interval of 1045 to 1257. Furthermore, they looked at the side effects. In 2,268 children 5 to 11 years of age, with 1,518 receiving the 10 microgram doses, 2 doses, with 750 getting the placebo, they compared local reactions, and they found similar to what we found in adults: redness, swelling, and pain at the injection site. And for systemic reactions, typically fatigue, fever, headache, and chills at no higher rates than what we saw in the adolescents and adults. A similar frequency and severity, mainly mild to moderate, lasting a day or two, as found in adults. No serious adverse events were reported in these trials. Additional doses of COVID-19 vaccine have been approved. And we're going to start with Johnson & Johnson's vaccine, Janssen COVID-19 vaccine PF. This was previously approved as a single-dose vaccine for those 18 years and older. Now it's recommended for all those who have received 1 previous dose, regardless of risk status or immunocompromise, to get a second booster dose at least 8 weeks after that first dose. They may receive instead, as I'll talk later, an mRNA vaccine. Trials showed the boosters work. They improved or increased the immune response and achieved an acceptable safety profile in terms of reactions and side effects. Furthermore, we have additional doses recommended for those who are moderately or severely immunocompromised who completed the 2-dose mRNA vaccine series of either Pfizer or Moderna. Though we knew from the early on that those individuals failed to achieve efficacies among their non-immunocompromised peers. All are to get a third, not a booster dose first, of an additional mRNA vaccine, a full dose of the Pfizer-BioNTech or a full dose of Moderna, at least 28 days after completion of that second dose. Now, studies have shown they see the same mild to moderate reactions as with the first 2 doses, with most of those reactions being fatigue or pain. Limited evidence shows improved response with this 3rd dose. Now, for the moderately or severely immunocompromised, we're talking about 3% of the US population. These are, it turns out actually in the studies since we started vaccinating against COVID-19, fully vaccinated, moderately or severely immunocompromised individuals actually form a large percent of those who are hospitalized with breakthrough cases despite vaccination. That is, most of the people who end up in the hospital with COVID despite having been vaccinated have moderate or severe immunocompromise. Examples of these conditions include those on active treatment for solid tumor or hematologic cancers, immunosuppressive therapy for solid organ transplant, CAR T cell therapy or stem cell transplant, syndromes like DeGeorge or Wiskott-Aldrich, advanced or untreated HIV, inactive immunosuppressive or immunomodulatory meds. Booster doses for mRNA COVID-19 vaccines were also approved with new recommendations for a booster dose 6 months or more after the 2nd dose. Pfizer, you get a full dose. Moderna, you get a half dose. Most vaccinees don't need a booster. It's only for certain groups, as a booster dose may reduce risk or spread in these groups. For those 65 years and older, those are residents living 18 years and older in long-term care settings. Those are 50 to 64 years of age with certain medical conditions that increase the risk for COVID. The vaccine booster is also suggested for those 18 to 49 years of age with certain medical conditions, and those 18 to 64 at increased risk because of exposure problems. We finally have also new recommendations about mix and match for COVID vaccines. These permit substituting a dose of one vaccine with another. Individual risk conditions that might lead to such conditions: concern with thrombosis with thrombocytopenia syndrome, seen only in females less than 50 years of age, albeit rare, seen only with Johnson Janssen vaccine. Those people might want to get their booster as an mRNA vaccine with a single dose. Also, concern with myocarditis and pericarditis, seen only in males less than 30 years of age, albeit rare, only seen with Pfizer and Moderna mRNA vaccines. Those might want to boost with a single dose of Johnson Janssen vaccines. Studies show mixing and matching works just as well or better, and it's just as safe. So in summary, you should be able to relate the latest recommendations for flu vaccine. All vaccines are now quadrivalent with 2 new strains, new recommendations on timing, new rules for flu vaccine allergy history, the latest recommendations for COVID vaccination, likely Pfizer vaccine today for those 5 to 11 years of age, 3rd doses for some immunocompromised, boosters for some, and mix and match now permitted. I am so sorry I've gone over time, but I'll stick around for questions or answer them from email.
Yes, thank you so much, Dr. Jacobson. Thanks for covering so much in a shorter amount of time. We appreciate it. And thank you also for being willing to share the slides with us. I think that'll be great to go back and reference those. So yeah, do we have any questions for Dr. Jacobson? Again, you can unmute yourself or put them into the chat. We are a couple minutes over, but Dr. Jacobson said he would stick around. So if anybody has any questions, we'll open that up right now.
I am not a clinician, so there were a few terms I did not understand. Could you tell us what you meant by certain proportion of people in the study seroconverted?
Seroconverted meant they achieved high levels of antibodies shown to prevent disease and protect against serious or moderate infection. So they had reached the desired antibody level.
Okay. Thank you.